Course and prognosis of systemic gonorrheal infection in women. Acute gonorrhea is usually seen either in young girls or in the prostitute class and is characterized by the usual features of an acute infectious disease. After an incubation of 10 to 14 days, which, however, in some cases is as rapid as 24 hours, the patient is seized with severe constitutional symptoms as chill, high fever, and rapid pulse. The local symptoms are, as a rule, very acute and may rapidly invade the entire genital tract, giving rise to acute endometritis, salpingitis, and peritonitis. Metastatic processes are not uncommon in these cases, as involvement of the joints, endocardium, and even meninges. The course of the acute infection is about 6 weeks, after which time the case, with careful treatment, may recover or pass into a subacute or chronic state. The majority of gonorrheal infections in women are, however, from the start subacute or chronic in type, and it is this larger and more usual class which is the more difficult of diagnosis and treatment. The onset may be so insidious as to deserve the title of latent gonorrhea. These cases usually present a very typical picture if the physician is on the alert and is aware of this form. Gonorrhea is essentially an infection which tends to remain chronic rather than to recover. Exacerbation of symptoms after apparent cure are very frequent. These may be especially noted at the menstrual period. Again, in a case supposedly cured, an attack of grip or any indisposition which affects the general health and brings it below par may start an acute exacerbation of symptoms. The symptoms thus excited are usually those of urethritis, cystitis, or cervicitis. The further complications of endometritis and salpingitis are especially frequent in these chronic forms, but space will not permit the consideration of these more purely gynecologic conditions. Joint involvement may occur with these exacerbations, and in certain cases, where the invasion has been extensive and the course protracted, the patient seems to lapse into an almost septic state. The picture of the chronic gonorrheic is pitiable indeed. There is usually loss of weight, more or less anemia, general lassitude, and mental depression. She is the victim of menstrual disorders, dysmenorrhea, menorrhagia, and a chronic leukorrhea. The prognosis of a given case depends on several factors, the most important being the virulence of the infecting gonococcus. The resistance of the tissues and the intelligence of the early treatment are also of importance. An acute gonorrhea contracted from an acute gonorrhea is usually most resistant and chronic, but this also depends on whether the infection be a high or low one. Intelligent treatment at the onset may affect the prognosis materially. Thus, if the woman be impressed with the importance of constant conscientious treatment, much may be hoped for. In cases of married women, it is not enough to treat the wife. The husband must be reached in some tactful manner and put under treatment, and sexual intercourse prohibited during the course of the disease. Cases of mixed infection where, at the time of infection, the gonococcus is in a very attenuated form and the pyogenic organisms active may give at the onset the clinical picture of a most virulent gonorrhea. These cases, however, offer a good prognosis and usually make a satisfactory recovery. 2 cases which have occurred in the experience of the writer illustrate the foregoing types. Miss L, age 18, came to my office complaining of a burning discharge and painful burning micturition. On examination, the vulva was found to be the seat of an intense inflammation, the hymen ruptured, and a thin greenish pus discharge pouring down from the vagina. On further questioning, the patient admitted that she had been betrayed by her lover. A smear showed abundant gonococci. She ran a very acute course with active urethritis, cystitis, and cervicitis. Fortunately, the infection was held at the cervix and the uterus and tubes not infected. The patient has been most faithful as to treatment. 1 year after the first visit, she had an acute appendicitis, and I advised operation. At the time of the operation, on examining the uterus, tubes, and ovaries, all appeared perfectly normal. This case is still under observation and has been most resistant to treatment. She has a chronic urethritis and cervicitis, which light up with any slight indisposition. Over a number of months, the symptoms are gradually improving and treatment is still continued. As far as can be ascertained, no further indiscretions have occurred. Mrs. W., age 20, married 6 weeks. History of difficult coitus, vaginal outlet being very small, and as a result, considerable trauma. Patient complained of a profuse discharge and pain in right lower abdomen. Her general condition poor, she ran a slight temperature, was pale. Examination of abdomen showed acute tenderness over McBurney's point, vaginally a violent vulvitis with a greenish thin pus pouring down from the vagina. Smears and cultures were taken for further examination. The case clinically was a virulent gonorrhea. She was kept under observation for about 24 hours, during which time active douching was started. Bimanual palpation failed to show any involvement of the right tube, though this could not be excluded in the presence of the vaginal discharge. Operation was advised as the temperature and tenderness persisted. I removed an acute appendix and again found normal uterus, tubes, and ovaries. The wound was closed without drainage and healed by primary union. The vaginal condition was treated with Protergol, 4%, and at the end of a week, all active inflammation had subsided. Her recovery was uneventful. The smear and culture in this case showed a very attenuated gonococcus and staphylococci. The husband was approached and a history of a gonorrhea 9 to 10 years previous to marriage obtained. The husband considering himself quite well at the time of his marriage. He was referred to a genitourinary specialist who reported that he had a urethral stricture and pus in his urine. The husband put himself under active treatment until his urine had cleared up. The wife made a complete recovery, and a careful examination a year later failed to disclose any trace of the inflammatory process. Curability of gonorrhea. Can gonorrhea be cured in women? It would seem that the consensus of opinion is that one can scarce be certain of a cure. A certain percentage of cases of acute urethritis recover completely. When the cervix and endometrium are involved, the question of a positive cure becomes more uncertain. A large majority of these cases, after careful, persistent treatment, are apparently cured and are discharged as such. It is impossible to assure such a patient, however, that the process may not start up again at some time under various conditions. Before discharging a woman as practically cured, she should prove the following examination. 1. That leukorrhea shall have ceased. 2. That a smear and culture taken from the cervical secretion shall show no gonococci. 3. That Skene's glands shall be free from purulent discharge. 4. That Bartholin's glands and ducts shall be free of pus. 5. That the complement fixation test shall be negative. These tests should be made on several occasions and near the time of the menstrual congestion. No douche should be taken before the examination, and the patient advised to take highly seasoned food and stimulants, which may excite a latent process into activity.